Welcome to the orthopedics unit, a specialty that is near and dear to my heart because looking back, I was baptized by fire as a new grad. As a student, I did only two ortho cases total. And my very first job was to be the ortho princess, quote unquote, who was going to be trained to replace the ortho queen who was electively choosing to leave the workforce. So what I want you to take away from this situation that occurred to me is that you will probably be put in situations that make you uncomfortable. But you need to have a can-do attitude that's willing to learn new things, because no matter how uncomfortable you are at first, you can learn a lot through that time and it can make you better. So embrace those opportunities whenever you can. Know that this is a pretty big unit, and so I recommend that you take these things in small bites so you don't get overwhelmed. The first thing we're going to talk about in this unit is the fact that orthopedics focuses on disease, anomalies, or injury to bones. Orthopedics is not solely devoted to the bones in the body. However, it includes the tendons, ligaments, joints, and muscles of the body as well. Your TED Ed video this week is devoted to tendons, ligaments, and joints because those areas can be easily mixed up. If you're a little rusty on your bones and muscles, I recommend you play around on two fun websites called Whack-A-Bone and Poke-A-Muscle. They're really fun. I added them to the bookmarks portion of your 202 course, and you'll find them under the bookmarks on the resources page. Knowing what makes up this orthopedic specialty then leads us to want to know why our musculoskeletal system is so important to our bodies. Well, it's very important because it supports the body. The bones of our body, our skeleton, produce red blood cells. They store calcium for metabolism, and they protect our organs, and they allow us to move. Tendons attach muscles to bone, and ligaments attach bone to bone. I don't have any nifty mnemonic devices for you there, but when I was a student and I was trying to remember the difference between a tendon and a ligament, I always thought of the ACL. And I knew the ACL kept my knee stable, and I knew my knee was made of bones. Therefore, I knew that the ligament, which was the L in ACL, attached bone to bone. And that's how I remembered it. Okay. Right here. On your first official slide, you'll recall from your reading that the skeleton is divided into the axial skeleton and the appendicular skeleton. Make sure you know which bones make up the two parts of the skeleton. It's in your book. Take a moment to refresh your A&P knowledge and think about the vertebrae and ribs. How many vertebrae make up the vertebral column? How many are in the vertebral column excluding the sacrum and coccyx? What are the 5 components of the human spine? Which ones move? Which ones don't? How many bones make up those sections? Refreshing this now will help you when it's time to go over it again next semester during neuro, and it's just good for you to think about. Another thing to think about is how many ribs do we have? Remember, your answers should be in pairs. And what is the name of the specific cartilage belonging to the ribs? Back to your slide, your bones are made up of 2 components. The cortical bone is compact and hard and is found on the surface of the bones. Oh! What is this? Sorry about that. Okay. The cortical bone is compact and hard and is found on the surface of the bones. That is important when you're scrubbing because you will come in contact first with cortical bone, unless you're dealing with a fracture. But the other component of the bone is the cancellous, or spongy bone, which is found on the ends of bones and in the inner layer. Refer to your textbook to remember what is found in that cancellous layer and which bones are responsible for making new blood cells. It's important for you to know that for bone grafting purposes, the bone tissue that will be harvested will be cancellous because it has the cells needed for bone growth. Yes. On this next slide, we will continue talking about bone tissue with an emphasis on the medullary canal. The medullary canal is the centralmost portion or cavity of bone shafts. So for long bones, the order of tissue from outside to inside, back to outside again, is cortical bone, cancellous bone, medullary canal, cancellous bone, cortical bone. That is through and through a long bone. Red marrow is found in the small spaces of cancellous bone and is highly vascular, while yellow marrow consists mostly of fat cells and connective tissue and is in the medullary canal. If you get an opportunity to observe or scrub a total knee procedure that uses bone marrow autograft instead of bone cement, you will see exactly what I'm talking about. This technique is fairly new and not everyone uses it yet, but if you get the chance, please take that chance because you will get to see this marrow actually in use. Recall what you already know and write down which type of bone marrow produces blood cells and hemoglobin and where is it found. On this slide, you'll see different anatomical components of the long bone. Attached to the cortical layer, which is the outside layer, remember, is a protective covering called periosteum. Periosteum, like I just said, is protective, and it is what tendons attach themselves to. And you remember, tendons attach what to what? Write it down. You can never write these things down enough times because the more you write them down, the more you'll remember them. The periosteum consists of a dense external layer that contains blood vessels and an inner layer of connective tissue. That sounds like something we might want to preserve, but in actuality, it has to be scraped away from the surface before surgery can be performed on the bone. This is particularly evident in fractures and is an important step of the procedure. It is accomplished with a periosteal elevator. There are many periosteal elevators that are used for this task, and they are selected based on the size of the area that they're being used. They range from elevators as small as the Freer, used in the metacarpals and wrist, to a very large one called the Cobb, which we use on the femur. Look up the Freer and look up the Cobb in your instrument book, and then I will bring some to class for you to see and practice passing. So, periosteum is on the outside, and endosteum is the inner lining of the channels of long bones. It fills the interstitial spaces, which are the sponge-like space of cancellous bone. The endosteum initiates bone growth and provides nutritional substances to bone. The periosteum contains the specialized cells that secrete the matrix for bones to actually grow. So we need endosteum to initiate bone growth, and we need periosteum to actually do it. It's also important to note that the structure and shape of bones is important. This next bit of information noted on the sectional portion of the picture on your slide, right here. Right there. Long bones, in addition to the medullary canal and the production of blood cells, are also characterized by a diaphysis and an epiphysis. Note on your picture that the diaphysis is in the middle while the epiphysis is on each end. The epiphysis is where the cartilage is supposed to be, and that's really important in joint anatomy. And the transition between diaphysis and to epiphysis, from middle to end, is extremely important in fracture pathology, because that's where growing bones in children and adolescents are actually growing. Fractures through what is called the epiphyseal plate will complicate the reduction of the fracture because you can't just plate and screw the growth plate. Also, there's potential for the growth of the bone to be affected. So these are all perioperative considerations made by your orthopedic surgeon. But in time, you're going to be able to anticipate these decisions and be that much more prepared for your cases. Lastly, obviously not every bone is a long bone like this one. Some are short, some are irregular, some are flat, And so make sure you take a moment and you study those different kinds of bones as well. And your book is very kind and gives you examples of all of them. I'm going to stop your video now and we'll resume with the next. This next slide takes you to page 766 in your book. It provides you with some bony landmarks in the body. You will want to know these landmarks and add them to your medical terminology. These landmarks are essentially bone irregularities or special characteristics, if you will, of specific bones that function as areas of attachment for our tendons and ligaments or provide a passageway for blood vessels and nerves. The terms are both generic and specialized, so know that multiple bones may have a particular landmark. For example, a foramen, which is generic, but each foramen is specific to that bone because it allows specific nerves and blood vessels through it. Take the time to define these terms using your box in your textbook and then find the bones that have them. When you get to the obturator foramen, make a note that you've just encountered the largest foramen in the human body. Your next slide covers bone healing. If you haven't already, you will discuss this in your workbook, so make sure you understand the 3 phases that pertain to bone healing. This process is similar to soft tissue healing, except this process takes quite a bit longer, upwards to 6 months. On this next slide, the most important concept to walk away from is that what is a joint and what classification does it fit within? In order to answer that question, you need to know that joints are where 2 bones meet, and they are classified by their degree of movement. So as you can see, according to the definitions of each classification, we can put every joint in the body into one of these categories. Synarthrosis joints would include joints of the skull and face, some of the ribs, but not all of the ribs. Not all of the ribs don't move, just some of them. Examples of amphiarthrosis joints would include the symphysis pubis and the joints of the vertebral column. The third category can be called either diarthrosis or synovial. Make sure you know that this has 2 names. But for all intents and purposes, I will refer to them as diarthrosis to keep the words similar. The joints that fall within the diarthrosis category are all of the commonly thought of joints: shoulder, elbow, knee, hip. It is this category of joints that you will spend the majority of your time scrubbing cases while in the ortho specialty. The diarthrosis joints are special because they possess joint capsules, and the joint capsule is lined with synovial membranes and filled with synovial fluid. An absence of synovial fluid in these joints leads to complications with the joint, and pain is usually the major symptom. It's very important for scrubs to be familiar with joint movement terminology. Diarthrosis joints move in up to 4 different directions: flexion, extension, abduction, and adduction. Off to the side of this slide, make sure you know the definitions for each. Put your own joints through each range of motion. Practice on someone else. Not only should you know this for this unit, but you will be expected to assist your surgeons during cases with joint manipulation for their visualization. Your next slide is a detailed image of a diarthrosis joint. Pay close attention to the different components, and can you identify the medullary canal? Can you see cortical and cancellous bone? Do you see that between the two bones there is that synovial membrane I mentioned earlier? And inside that membrane is the synovial fluid? On the ends of each bone, a healthy joint will be covered in articular cartilage. Remember, we don't do surgery on perfectly healthy anatomy, right? So that articular cartilage will be damaged or deteriorating when you're there. So now that you have a solid grasp on joint classifications, let's talk about the different types of joints. Remember, amphiarthrosis, synarthrosis, and diarthrosis are classifications. Joints fit in the classifications. And then they get more specific and they are labeled as a type. So on your slide there's a variety of different types of joints. First is the hinge joint. I'm sure you've got this one down, right? In what directions can the knee and elbow only move? I hope you said flexion and extension only. Next is a saddle joint, and it's pretty specific as it requires the bones to have a complementary convex and concave shape. And the thumb joint is the only one in our bodies that fits that description. The thumb moves in all four directions. And the next type is a gliding joint, and a prime example of a gliding joint would be the vertebra, beginning below C2 and above L5. Those specific vertebrae glide on top of one another. The ball and socket joint isn't hard to determine, the hip and shoulder joints, and they are remarkable because they truly move in all four directions too. Pivoting joints provide rotation only, which is why C1 and C2 fit into this type of joint. They don't abduct or adduct like the ball and socket, but they do more than just hinge, so they are their own type. The last type of joint is a condyloid joint, and the wrist is the leading condyloid joint at the point where the radius articulates with the carpals of the wrist. Finally, we have to talk briefly about sesamoid bones, which are not technically a joint, but they're free bones that are embedded in tendons surrounding other bones and nearby joints, particularly in the hands, feet, and knees. Your next slide reviews the purposes of tendons and ligaments. Remember, tendons attach muscle to bone, and ligaments attach bone to bone. This is of particular importance in the movement of our body because tendons facilitate movement of muscles because they're attached to bones. So, in a nutshell, bones move. Bones that are attached to muscles by way of tendons allow muscles to move. Muscles provide the power behind the movement. Ligaments, on the other hand, attach bone to bone, which is also important for movement, but not for power. It's for stability. You remember when two bones meet, we have a joint. If the joint moves, there's likely a ligament there. The ligament stabilizes the joint. Where muscles attach, there is only one bone. Therefore, there is no joint. Got it? The third and final area we will cover on this slide is the fact that some tendons are actually aponeuroses, which is defined by a broad sheet of fibrous tissue that takes the place of a tendon in sheet-like muscles and provides a wide area of attachment. And this is particularly noticeable on the abdominal muscles to our midline. Your next slide shows the muscles of the human body in the anterior position. Quick review. Can you define anterior and posterior, distal and proximal, superior and inferior, cranial and caudal? Make sure you can. Remember, directional terms are very important. Your body has 3 different types of muscles in it. Can you name them? We've covered several types of smooth muscles this semester by talking about internal organs. This unit is covering the striated skeletal muscles. And next semester we will cover the cardiac muscle during the cardiac unit. Which of these 3 are involuntary? which is voluntary. Move on to your next slide and see the muscles of the human body in the posterior position. Surgical technologists are expected to know the major muscle groups of the human body and where they are located. Take a moment right now and point to these examples of bones, ligaments, tendons, and muscles on yourself or on a partner. If you're unsure of a particular example, write it down and look it up. So here we go. Find your femur, your fibula, your humerus, your tibia, your olecranon, your clavicle, your radius, your ulna, your calcaneus, your scapula, your anterior cruciate ligament, your posterior cruciate ligament, your biceps tendon, your Achilles tendon, your quadriceps tendon, your gastrocnemius, your deltoid, your pectoralis major, your hamstring, the latissimus dorsi. I could go on and on for a long, long time, but you get the idea. Hopefully you noticed that I bounced all over the body, anterior to posterior, superior to inferior, because in reality, the surgical schedule is going to bounce all over the place too. You have to be able to think, where is that located? How will we access it? What position will the patient be in? What drapes do I need? All of these things completely dictate your surgical procedures. All right, time to pause again. I'll see you back in a little bit.